So in video 5, we're going to run through the second stage of labour, so baby being born, the third stage of labour, so your placenta being born, we're going to run through what happens after baby's born and the role of the partner. So second stage, okay, what's happening physically? So dilatation and effacement are complete, and so this is the phase where baby's moving down through the birth canal and being born. Your contractions slow down a little bit, usually in this stage. So we'll find that they get a little bit longer, maybe 70, 90 seconds long in some cases, but whereas towards the end of the first stage, you might have been having contractions every 3 minutes. In the second stage, they might actually space out a little bit, and now you might only be experiencing them every 4 to 5 minutes. So just to know that that's okay, that's to be expected. Each contraction is going to push baby further down into the birth canal, and your pushing is going to move baby along as well. The physios are going to talk about pushing techniques in their class 5 video, so tune into that. Baby's going to move under the pubic bone, his head is going to crown. Your midwife's usually going to ask you to stop pushing and just breathe at this point. First baby's head's going to be born and then baby's body. So to explain that, we know that babies fit perfectly through the pelvis in this position. So he's going to move through the pelvis during the course of the first stage. Your cervix is going to open to 10 centimeters dilated, and baby is going to get pushed into the birth canal. Once he enters the birth canal, usually your pelvic floor muscles, they'll just rotate him around slightly and just straighten him up. Usually the optimal position for baby to be in moving through the birth canal is him looking at your coccyx. So his nose facing your coccyx. So he'll be like this. With each contraction, what's going to happen is you're going to piggyback what your body is telling you to do. So if you have no epidural and you're feeling strong contractions and a huge amount of pressure, and you'll find that your body will almost be involuntarily pushing. So you just piggyback that and you just push with your body, join in your body, okay? And your body will guide you as to what feels right. If you have an epidural on board, you might not feel that all of this is happening. So this is where your midwife is going to coach and guide you. So she's going to be able to explain very clearly with you like how you might imagine you might feel like you need to push. And this is going to help guide you as to how to go about moving baby through the birth canal. You might not feel the contractions, but your midwife will be able to let you know when they're there, so that the same theory is applying. When there's a contraction there, your contraction is moving baby down through the birth canal, and you're pushing or joining in and helping move baby along. So each contraction pushes baby further down into the birth canal. The contraction goes away and baby slips back just a teeny bit. Okay? Then you're going to have a break until the next contraction starts to build. You're going to join in and you're going to move baby further down through the birth canal. Eventually, baby's going to reach the point where he's moved under this pubic arch. Okay, so what is the significance of baby moving under the pubic arch? Usually, it's that as your midwife, we'll be able to see just a teeny sliver of his head. Okay, how long does it take for him to reach that point where he's moved under the pubic arch? Usually on your first baby, could be about 40 minutes. So it would be normal for you to be pushing with contractions for 40 minutes and the midwife still maybe not see the top of his head, okay? So just to know, to kind of have that expectation of what is normal on your first baby. Once we start to see the top of baby's head, we will of course let you know, and your pushes will remain the same. So you're still pushing in exactly the same fashion. The only difference now is that we can now physically see a little bit more and a little bit more and a little bit more of baby's head with each contraction. Eventually, we're going to reach a point where baby's head is now crowning. So this is where the largest part of baby's head is going to be born. Again, to put like a really vague but average timeline on it, from the time we see a little sliver of baby's head on your first baby, we'd expect baby to be born kind of in about 20 minutes or half an hour. Sometimes sooner, but typically 20 minutes to half an hour. So eventually we reach a point where baby's head is crowning. So the midwife will usually let you know nearly a contraction or two before this actually happens, so that you're expecting it. And when baby's head is crowning, what we like you to do is just to breathe baby out, okay? So slow down with the pushing and just slow, controlled breaths, and the pressure of your womb moving baby will deliver baby's head. The reason that we like you to breathe as opposed to push, actively push during this part of the second stage is just to take the pressure off your perineum. So it just allows that skin just to stretch nice and slowly. So baby's head is crowning, next contraction builds, and you just and that's your baby's head born, okay? Before baby's body is born, okay, and before the next contraction actually even begins, your pelvic floor is just going to rotate baby around to a 90-degree angle, okay? So this happens without us doing anything and without you doing anything. You're just going to notice your baby's head turn to a little 90-degree angle so that he's now facing towards the side, this way or this way. This is your pelvic floor helping baby to align so that baby's in a perfect position for the shoulders to deliver nice and easily. The next contraction will then build. So as I said, the contractions may have slowed down for the second stage, but once the head is born, usually that second contraction to deliver the body will usually start to build quite soon after, so within a minute. So the next contraction will begin and baby's top shoulder is going to be born, and then baby's bottom shoulder is going to be born, and then baby is usually delivered, kind of slips out and is born usually in a gush, with a little gush of whatever amniotic fluid is left inside. And baby's going to be delivered up onto your chest where he'll do skin to skin for an hour. We'll have a nice warm towel ready to go, and we just pop that warm towel over baby, okay? Maybe giving him just a little bit of a dry, all right? You'll have a hat as well, a nice warm hat, and we'll pop that on his head. So that's your baby born. How you might be feeling during all of this. So your contractions will slow down and they may change in character. You'll have a huge urge to push, especially if you don't have an epidural. You'll feel pressure to the rectum and the pelvic floor. Again, this is completely normal. And that stretching of your perineum as baby's head is born, it may cause stinging. So it's just, again, just to know this is completely normal. What you can be doing during this stage. So we say go with your pushing urge. Don't be afraid of the strength or intensity needed to bring your baby into your arms. So your body will never encourage you to push more intensely than it would like you to. So go with what your body is telling you or guiding you to do. Take deep cleansing breaths both before and after each contraction. So this is just to get loads of oxygen into your body both before and after the contractions. Listen to your midwife, especially as baby's head is crowning. She'll ask you to stop pushing and just breathe so that baby's head is delivered nice and slowly. So that's your baby born. However, your placenta is still inside. Okay, so let's just imagine, okay, and our placenta is still connected to our baby. Okay, so here at the Rotunda, we would aim to practice optimal cord clamping. So this is where we just, when safe to do so, allow maybe 2 or 3 minutes for the blood that's in the placenta and the cord to travel through to the baby before we go clamping and cutting the umbilical cord. So we'll allow that to happen. Benefits of delayed or optimal cord clamping are that baby is getting an increased volume of blood. Baby is getting an increased volume of oxygen carrying red cells, increased iron stores, and increased stem cells. Okay, so there's loads of benefits there. So when safe to do so, that's something we would automatically practice. Once the cord has stopped pulsating, now we need to pop a cord clamp on. Okay, so baby will still be on your chest. I'm just going to turn him around so you can see. So cord clamp looks something like this, and we just apply that to the cord. Okay, and then we have another silver cord clamp up on the delivery suite, which we'll apply also. And your partner will be asked to cut somewhere between here, between the 2 cord clamps. So that is your placenta now separated from your baby. Your baby is still doing skin to skin, but I'm going to pop this guy down just so I can explain to you what's going to be happening next. So here in Ireland, it would be common practice to actively manage the third stage. So this involves giving an injection of oxytocin just into the thigh, and we know that oxytocin makes contractions happen. So what's that going to do is it's going to help the womb just to contract and contract down, which is going to encourage the placenta to separate away from the wall of the womb. And giving this oxytocin or practicing active management will reduce the percentage or the risk of postpartum hemorrhage. That's why we would give it nearly as a default here at the Rotunda. So what's going to happen physically? So the placenta is going to break away from the uterine wall as it contracts down. And what you're going to feel, so if you don't have an epidural, you might feel some mild, niggly uterine discomfort. If you do have an epidural, you might not feel anything. But what you will notice, whether you have an epidural or you don't have an epidural, is a sudden gush of dark blood. Okay, so what's happening there is this is where the placenta separated from the wall and those little blood vessels severed. Sometimes they can just create a little gush of blood. So if you feel this or notice this, it's just important to let your midwife know. And this is usually a little indicator. It's giving us a little clue that the placenta is ready to be born. To deliver the placenta, your midwife will usually just guide the placenta using the cord. So she'll just take a gentle grip of the cord and she'll usually ask you just to give a little cough or a little push and the placenta will be delivered. The placenta is probably about this size. It's quite squishy, so it's very easy to deliver. This is your placenta, so we will ask what you would like to do with your placenta. So maybe give that a little bit of thought over the next couple of weeks and months. So if you'd like to bring it home, that's no problem. Just let us know and we'll have it ready for you when you're leaving the hospital. Or if you'd like us to dispose of it, that's no problem at all. You may have heard of something called a physiological third stage. So this is where we're not actively managing the third stage and we're just trusting that your body is going to deliver the placenta in exactly the same way as it delivered the baby. So generally when everything is very low risk, you've got a low risk pregnancy, you've had a very low risk labour and birth with no intervention. At times like that, it might be appropriate to consider a physiological third stage, but this is something that a decision you would make in discussion with your midwife or your obstetrician. But the general day-to-day, the default would be the active management of the third stage. After baby's born, so after baby's born, we're going to give baby a little snuggle, known as skin to skin, for the first hour. And in our feeding video, we spend time talking about all the lovely benefits of skin to skin. Baby's probably going to be hungry during this hour of skin to skin. So again, we do run through it in the feeding video, but after about 20 minutes, baby will probably start licking his lips, rooting around, showing you some hunger cues, and your midwife will help you to latch baby on, and he can have his first feed. So the initial exam of the newborn. So usually after baby's had his feed and a bit of skin and his hour of skin to skin, the midwife is going to perform a head to toe check, which we call the initial exam of the newborn. And she'll talk you through this check that she's doing. So we're just checking baby's fontanelles, his eyes, 5 fingers, 5 fingers, 5 toes, 5 toes. It's a very physical check of baby. Then we'll ask for your consent to administer a vitamin K injection. So we give all babies born in Ireland a vitamin K injection. So not to be confused with vitamin D, which is the vitamin that we give for the first year of life to help with calcium absorption. This is a different vitamin. And what vitamin K does is it helps with babies' blood clotting. So babies are born with no supply of vitamin K. So it's best practice to help boost the supply at birth, just in case baby were to have an unexpected internal bleed. He now has the vitamin K that's going to give him the ability to clot that off and sort out that little problem. Usually the synthetic vitamin K will wear away after about a week or so, but by that stage your baby is now synthesizing and making their own vitamin K supply. So your midwife will talk to you about that after baby's born. We need to put some name tags and security tags on your baby. So we'll usually put 2 name tags on, one on their hand and one on their foot, and a little security tag on their other foot. And they're usually applied while you're doing your skin to skin. And then just to mention oxygen and suctioning and resuscitation. So it's just to know that as standard, like babies get a little squeeze, their lungs get a little squeeze while they're making their way down through the birth canal. So typically there would be no need for any suctioning. And when they come out, they take a big breath of fresh air, which is full of oxygen. So generally they just do this themselves. From time to time, we might have a baby maybe who's a little bit slow to take their first breath. And if that is the case, your midwife will ask you if she can cut and clamp the cord quickly. She'll usually take baby over just to a heated cot in the corner of the room where she can properly assess baby. She may need to give some suctioning and a little bit of oxygen, but once baby pinks up and takes that first breath, he'll be back over on your chest doing skin to skin as normal. There are times where maybe at birth we'll have a little bit of foresight, okay? And we might say, probably no harm to have a paediatrician here for the delivery. And usually, like taking the approach of better looking at them than for them. And in my experience, the times where we call the paediatricians, that quite often the babies come out kicking and screaming and we've no need for them. So times where as standard we'd have a paediatrician there for the birth would be any signs of fetal distress during the labour or during the birth, an instrumental delivery, emergency or unplanned cesarean section, a premature baby, or meconium in the water. Okay, so just to know that it would be quite normal for us to call the paediatrician for the birth for those instances. Okay, so after baby's born for mum, so once your baby's born and your placenta's born, your midwife will ask if it's okay if she just reviews your perineum. So she's just having a little look just to make sure everything is as it should be. If she feels maybe that there was a small little tear requiring some sutures, she will ask for your consent to perform some suturing, which is just another name for kneading stitches or for giving stitches. Any of the suture material that we use here in the hospital for perineums would always be dissolvable. So all perineal stitches will always be dissolvable, starting to dissolve by about 2 weeks and usually fully healed by 6 weeks. Sometimes people ask, is there anything I can do to help my stitches heal a little bit quicker? Absolutely. Nutrition is key. So be eating, a proper nutritional breakfast, lunch and dinner. And if you have leftover pregnancy vitamins, so you may as well take them because they're just going to help build your body up. You want to keep the area clean and dry, so just a daily bath or shower with just plain water to the area, and to change your maternity pads regularly. If you have an epidural, you'll be completely comfortable when we're performing these sutures. If you don't have an epidural, we'll administer some local anaesthetic so that the area is completely numb before we perform any suturing. A shower and tea and toast. So you'll probably be starving after you've had your baby and after you've fed your baby. So we'll make some tea and toast for you. And if you feel like a shower, absolutely, there are showers up in delivery suite and you can have a shower if you'd like. If you had an epidural and you can't walk to the shower room, we can give you just a little freshen up in the bed, just to tide you, fresh night dress, and just to tide you over till you get to the postnatal ward. And when the legs are feeling a little bit more like they usually do, a midwife or student midwife will walk you down to the shower area, and you can have a shower on the postnatal ward. Usually you're on delivery suite for about an hour and a half, maybe 2 hours after you have your baby. And that'll be plenty of time to do your skin to skin, have baby checked over, have a bit of tea and toast, have a shower, feed your baby. And then we're going to bring you down to the postnatal ward. So on the postnatal ward, you would usually stay there for about 2 to 3 days after a vaginal birth and about 4 to 5 days after a cesarean section. If you're attending the community midwife team, you'll have a different arrangement whereby you may possibly be given the opportunity to go home a little bit earlier. With the plan, the community midwives will pop out to your house daily and visit you postnatally for the first week. Lochia is the name that we give to postnatal bleeding, which it is absolutely normal to experience for up to 6 weeks. With this postnatal bleeding, things I suppose that we wouldn't consider completely normal would be, I suppose, very heavy bleeding, would be passing large blood clots, so anything bigger than a €2 coin, or noticing any offensive smell from the postnatal bleeding. So if you were to notice any of those 3 things, just let your GP or your community midwife or your maternity hospital know. The role of the partner in all of this, okay, so backtracking to the early stages of labour when you're both at home. So I suppose the physical support, being there and helping you with all the things that you need a little bit of help and reminding about. So they might be making little snacks and reminding you to eat them. They might be reminding you to drink water, reminding you that another hour has passed, and if you felt like you needed to run to the bathroom and pee just to empty your bladder to make a little bit of more room for baby, they'd be reminding you to do that too. They're probably putting your bags in the car, communicating with your family if that's your plan, making sure there's enough fuel in the car, helping you in and out of the bath. So really they're just there helping you with absolutely everything. And getting you into the hospital safely. In the hospital, they're being there amongst other things as well. They might be helping you put a TENS machine on your back. They might be helping you in and out of our bath and so on. An emotional support to each other, okay? So chances are this is new for both of you, and it's important to kind of be mindful of that. So chances are, if your partner is peppering around a little bit, it's just that they're probably trying to put on a bit of a brave face and trying to keep super cool and confident. So we cut them a little bit of slack with that, an emotional support to each other. You've got this video here and the previous labour and birth videos, which you're going to run through everything. Feel free to watch them again. You have the hospital website, which has some really useful information around labour and birth and when to go to hospital. You'll see there are online resources on the hospital website, so actually a PDF running through things you could be doing at home, a PDF running through when to go to hospital, and also a PDF running through all the, what is happening physically, how you might be feeling, and what you could be doing for each of the stages of birth, so check into that as well. If you feel you need to talk to somebody, pick up the phone. You'll be put through to reception and ask if you can be put through to an emergency room midwife, and we can answer any further questions that you might have. It's worth considering making a birth preference list as well. So a birth preference list isn't a birth plan per se, because with birth, you've probably heard this before, but we say the baby makes the plan. Okay, we're just kind of going with the flow on the day. But absolutely to make a preference list of all the things that we would, in an ideal world, like on the day. Many of these things are more so to do with our environment. So a birth preference list could be divided into, I suppose, 2 phases: the early at home stage and the established labour, established birth, coming into hospital. At home, you could spend time, because this could be your reminder on the day, so dimmed lights could be there. Don't forget to listen to my Spotify playlist that I put a bit of time into, or together we put a bit of time into creating. I might watch my favourite movie, go on a walk to encourage baby to get into a good position, have a bath, and so on. So maybe work on a little birth preference list for the at-home stage, and then again for in here. So have a little think about, what things could I bring into the hospital that might make my environment a little bit more comfy? So again, that could be, dimmed lighting. So pop that down. It might be bring in my speakers and I'm going to listen to my music on the delivery suite. It might be for my partner to practice a little bit of massage on my back that's going to keep me nice and chilled. For the midwife to remind me about the bath on the delivery suite in case I forget. So anything that you can think of that it's going to make things a little bit easier for you on the delivery suite, absolutely write that down on your birth preference list as well. And we recommend that you bring that birth preference list along with you to an antenatal clinic appointment where your midwife or your obstetrician will glance over the list, and they'll just be able to reassure you that, hopefully all of these suggestions that you have are brilliant, and they're all absolutely things that we would be able to, make available on the day, on the day you're in labour here in the hospital. And if there was anything that for any reason that we couldn't facilitate, it's at that antenatal clinic. That's when we discuss it, and again, you can come up with an alternative then, which is going to put you back in control, as opposed to just bringing this list along on the day. And if there wasn't something there that was achievable, well, now you're upset. That's going to interfere with your adrenaline, your oxytocin levels might go down, things might slow down as a result, So don't forget to work on and bring your birth preference list along to the antenatal clinic. Thank you.